Now, moving on to our first section, that is the principles of fracture management, how to reduce the fractures, what are the techniques for open and close reduction. In this section, we'll be briefly going through what is close reduction, and what are the different techniques, and what is open reduction, and what are the different techniques to do open reduction. So reduction, what do we aim for in reduction? Actually, we are aiming for adequate apposition of bones and normal alignments of the fragment. On average, what is usually said is that ideally the bone should be 100% aligned and 100% opposed. But if sometimes you cannot achieve that kind of situation, so at least more than 50% of contact surface area should be there with minimum permissible amount of angulation, which is usually not more than 4 to 5 degrees. Greater the contact surface area, more likely the healing to occur. Ideally, there should be 100% contact area between the two broken ends of the bone. But if by any means, if it's an unstable fracture, it cannot be achieved, the minimum criteria for having a contact surface area should be at least 50%. Now coming to the gap between the fragment ends, usually it's called as delayed union or non-union. So we have to remember that usually if the segments are kept undistracted, there will be gap between them, which may eventually lead to non-union. Or if they are not opposed properly, they still will not be in line with each other, eventually leading to non-union. So to prevent this kind of non-union or malunion, we need to make it sure that the fragments are opposed to each other and ideally almost 100% contact surface area, and there should be no angulation so that the malunion, non-union can be prevented. Fractures involving the articular surface, any irregularity, abnormal load distribution actually leads to arthritis. So usually with most of the joints, the acceptable limits is less than 2 millimeter of step off. If the articular step is more than 2 mm, we need to fix this because it will eventually lead to massive amount of arthritis. But in case of knee, you can take it up to 5 mm is acceptable limits. But it's not that. Usually when it's an intra-articular fracture, we must make it sure that there is no articular step because it will lead to severe arthritis later on. Now, how to do the close reduction? There are threefold maneuvers basically to do the close reduction. The first is the distal part of the limb is pulled in the line of the bone. For example, if the patient had, let's suppose, distal radius fracture, the hand will be pulled in the line of the force. Then as the fragments disengage, they are repositioned opposite to the where they are actually. We have to, this is what the role comes in of the history. We need to understand the mechanism of history. If the distal segment have actually gone dorsal, that means we need to push it in such a way that it has to come back into the volar position so the normal alignment can be restored. So one has to remember, first distract the apply traction to the distal part so that segments disengage, then do the reverse maneuver, which was the opposite of the maneuver which is causing the injury to the bones. And then lastly comes the alignment. We have to check it up that there is no malalignment in AP and lateral plane as well as medial lateral plane. That is, the bones are aligned in this plane as well as in up and lower plane as well. Now, how to do close reduction? Usually the indications include minimally displaced fracture. For fractures in children usually there's a very good healing potential, therefore close reduction is always a good option. Unstable fractures, which sometimes there's so much combination that doing an operative surgery on this kind of small bony fragments would be more disastrous for the patient. So actually, when the multiple fragments are involved, what we do is we give it a back slab, POP, or splint in form of it after doing the close reduction. Unstable fracture usually are reduced by closed methods. They are converted into stable fractures and then splint is applied. This could be in form of internal and external fixation methods as well. Sometimes, for example, if it's an open fracture, then you cannot only do a close reduction, then you have to move towards open reduction. But sometimes what happens is that actually there is a lot of combination and we have to stabilize the bones, so the proximal and distal end are fixed externally by use of some kind of external fixator, and then we can continue with the splintage. Now coming to the close reduction. That's told you the maneuver is traction and counter traction. That is, you reduce the fracture fragments by pulling the distal in the line of the bone. Then that is this reduces actually fracture fragments through ligamentous texas or ligament pull, because the ligaments would be there when the bone ends would be pulled. This will automatically reduce the fracture fragment to its place, and usually applied by using fracture table or bone distractor. Normally, bone distractor is rarely required. A fracture table is actually a kind of special kind of table in which, if suppose this was the bone which was injured and you are pulling in this direction, this is the distal segment, this is the proximal segment, then there has to be an area which can hold the proximal end. This could be in form of an assistant who's holding the proximal end and applying the counter traction, or it could be in form of a table which is actually holding the proximal end or fixing the proximal end, and then distal end getting distracted so that the fractures can be reduced. Now coming to the open reduction. Sometimes close reduction fails, or sometimes it's so much so that we have to go for an open reduction because it's indicated. So when is it indicated? For example, if close reduction fails, when there is a large articular fragment requiring accurate positioning. Why? Because in case of an article step, if it's left with close reduction, that will lead to severe arthritis of the joint later on. Or it could be for traction aversion fractures. For example, you are doing some kind of a close reduction, but instead of having a close reduction, we did not achieve the proper results. We did not achieve the kind of alignment or we wanted, and there is a chance that this may go into non-union or malunion. So then you move to open reduction. In this section, we've briefly discovered what are the different methods of reducing a bone. It could be in form of a close reduction, in which the joint or even there is no incision given and the bones are actually not opened. A close reduction is done under GA or under sedation in form of a local anesthesia, and the bones are actually opposed with almost 100% contact surface area with strictly alignment. We have to check whether in medial lateral plane and anterior posterior plane the bones are aligned properly. But if that fails, we may have to move to open reduction. Open reduction of the bone means giving it an incision under the anesthesia, opening up both the bones, reducing them properly, and fixing them in form of either in form of plate or screw, or it could be in form of a nail. Thank you very much. Keep watching sqadia.com.